Hi, this is Dr. Charles Fraser. I'm the director of the Texas Center for Pediatric and Congenital Heart Disease here at Dell Children's Hospital and the University of Texas Dell Medical School. I'm really pleased to share with you some of our thoughts on the three most important elements for a dedicated pediatric and congenital heart surgery program. First of all, the team. You can't have a great program without a great team, and it's often believed it's about just the surgeon, which is completely wrong. The surgeon is just part of an integrated unit, just like a baseball player would be. And so although it's important to have this surgeon that can do the right operation, the whole team is critically important, and that means anesthesiologists, perfusionists, OR nurses and techs, the critical care ICU team, bedside nurses, pharmacists, respiratory therapists, of course our cardiology colleagues, diagnostic imaging, social work, child life, psychology. It's really a village of focused caregivers. The next element that's really important that we see as critical to an optimum pediatric and congenital heart surgery unit is measurement. You know, we measure, it's often said, we measure what's important to us. Another way to think about it is if we're not measuring things, our retrospectoscope, our anecdotal recollection may either be too rosy or too negative. People often feel like the performance is either better than or worse than it actually is. So we measure everything that we know to measure, and then we ask questions about what more we should be measuring. And that's going to be an endless process, more recently driven by patients and families and what they want to know about outcomes and the performance of the program. But again, the core element is measuring everything that's possible. And then a corollary to that is that if you measure things, then what do you do with the information? And first of all, the measurement has to be believable and accurate. But assuming that's the case, then what do you do with the information? The more information you have, the more opportunity we have for rapid cycle refinement of the program structure, function, day-to-day operations. We ferret out problems and deal with them, hopefully in an effective way. It also allows a more holistic approach to the continuum of care, and we have developed what we're calling the Health Transformation and Design Program, really to look at those objective elements of outcomes to transform and design better ways to do things. Again, with the primary focus being on examining outcomes that are important to families, maybe some outcomes that we wouldn't have even considered historically. And then another important element is, does the team do this a lot? Now, there's several ways to think about this. There are objective data to conclude that larger programs, meaning programs that do more than 200, 250 operations a year, have better outcomes. Said differently, this specialty does not lend itself to part-time participants. So the smaller the program, the more unlikely it is that there's going to be a completely dedicated team. There will be one or more of those critical elements that I alluded to previously of an integrated, committed team that would be doing this on a part-time basis. And we see this all the time. We see programs where, say for example, there's one surgeon How can that possibly be safe? One surgeon cannot be in the hospital 24/7, 365. It's not possible. So a program should have sufficient numbers of operations to have more than one surgeon. Dedicated anesthesiology. If the anesthesiologists are here and there and doing this and doing that, and then, oh, by the way, adding complex cardiac surgery into their workload, not likely that they're going to have refined their skills sufficiently to operate and care for very, very small and delicate children. So there is a correlation between the size of the program and the ability to commit the right team, the right resources, and thereby achieve the very best outcomes.
What do you think about second opinions? Does it bother you when a family asks to get one?
Second opinions are not only encouraged, we're very supportive of family seeking second opinions. Patients that we see primarily that want to get an opinion from somewhere else, or patients that come to us for second opinions. These are really difficult decisions that families have to make, and sometimes they're very challenging management decisions for the care team. Some of the conditions we treat are very rare. Some of the management decisions can be controversial, or the family and patient just want to have reassurance that they're doing the right thing, or that the team is doing something that the general community of programs would agree is appropriate. So we always support families when they seek a second opinion. It's certainly not offensive to us, and we'll do everything we can to make achieving a second opinion or a third opinion or more effective, timely, and supportive of the family and patient's needs. Now, what we don't do is endorse other programs. That's not our role, either to endorse or castigate another program. That, of course, wouldn't be appropriate. We have certainly seen examples where programs, because of a competitive necessity, have said negative things about other programs. It's highly unprofessional. It's highly unnecessary, and we certainly do not support that. So our job is to help the families and support them. So in any event, second opinions are extremely valuable, and we very much support that notion.
What does it mean when you say it is a teaching hospital? Because I don't want people learning on my child.
Many times a parent will say to me, now, Dr. Fraser, are you doing the surgery? And I'll say yes. But this is a teaching hospital, and I will say yes. And will there be learners involved in the care of our child? And I will say yes. And I will emphasize that these are highly supervised individuals, that there are certain things that learners can participate in and certain things that learners cannot. In any teaching program anywhere in the world, there is the absolute commitment from history that comes with a sacred responsibility, and that is that the primary needs of the patient are of the utmost importance. It's fascinating that the best programs, and this is not unique to pediatric cardiac surgery, but the best programs are associated with academic medical centers that are associated with teaching hospitals. And so, yes, we very much are advocates of the academic enterprise. We very much support the importance of teaching our successors, but we also emphasize to families that this provides an optimum care environment. It provides an environment of intense scrutiny of all aspects of the care continuum, and at certain levels, perhaps a higher level of responsibility. So we find generally that families are very accepting of that explanation and understand it.
My name is Erin Gottlieb. I am the Chief of Pediatric Cardiac Anesthesiology at Dell Children's Medical Center and the University of Texas Dell Medical School.
What is a pediatric cardiac anesthesiologist?
A pediatric anesthesiologist is a physician who has completed a residency in anesthesiology and a fellowship in pediatric anesthesiology. A pediatric cardiac anesthesiologist has completed additional training in pediatric cardiac anesthesiology and primarily cares for patients with congenital heart disease.
Does every child with congenital heart disease need a cardiac anesthesiologist?
I do believe that patients with Down syndrome are best cared for at children's hospitals, where the team is very familiar with this special group, and I believe that patients with cardiac diagnoses should have access to a dedicated pediatric cardiac anesthesiologist for cardiac surgery and potentially other procedures, depending on the cardiac diagnosis.
As an anesthesiologist, what special things do you think about when treating a person with trisomy 21?
Patients with Down syndrome often present for cardiac surgery in the first year of life, but they may also present as neonates or young infants for non-cardiac procedures, such as the repair of duodenal atresia or the placement of a gastrostomy tube. In the childhood period, patients may present for other common childhood operations like tonsillectomy, appendectomy, or the fixing of broken bones. When a child with Down syndrome presents for any type of procedure, the anesthesiologist will be really interested in learning about the patient's medical history, surgical history, prior experiences with anesthesia, medications and supplements, allergies to medications, and developmental history. The anesthesiologist may want to learn more about airway issues like snoring, obstructive sleep apnea, or croup. Additionally, they may ask questions about a history of thyroid problems like hypothyroidism or symptoms related to the cervical spine. If a child has a cardiac abnormality, the anesthesiologist will want to review the last echocardiogram, last cardiology note, and will also want to know more about exercise tolerance or signs or symptoms of congestive heart failure.
What do you do to make sure that the patient is okay while under anesthesia?
Some of the special concerns that we have when we anesthetize patients with Down syndrome include small arteries and veins that can make vascular access difficult, the stability of the cervical spine, the potential for airway obstruction, small airways, and high vagal tone, which means that the heart rate can slow down considerably with some medications and procedures such as intubation. Pediatric anesthesiologists and pediatric cardiac anesthesiologists often have a great deal of experience caring for patients with Down syndrome and are prepared to manage these concerns.
Good evening. My name is Ziv Beckerman. I'm a congenital heart surgeon and I'm also the surgical director of the Adult Congenital Heart Program at the Texas Center for Pediatric and Congenital Heart Disease.
What is adult congenital heart disease and how common is it?
Every patient that was born with a congenital heart defect and is now an adult is considered to be an adult congenital heart disease patient. Some of these patients, actually most of them, had previous cardiac interventions, but some did not need any intervention during their childhood. Down syndrome patients frequently have congenital heart disease, and most of them will need ongoing care well into adulthood. To date, there are more adults than children living in the United States with congenital heart disease. Over 1.4 million adult congenital patients are alive in the United States alone, and more than 40,000 congenital heart disease patients turn 18 every year.
Why should an adult with adult congenital heart disease be followed in a congenital cardiac center?
Most patients with congenital heart disease are not cured of their disease. They get sick more often than the general population. Lifelong follow-up is needed, but 30 to 50% are lost to follow-up as they turn into adulthood. Certain congenital cardiac centers, like the Texas Center for Pediatric and Congenital Heart Disease, had developed the required support systems to care for adults with congenital heart disease. Adults with congenital heart disease are very much different from adults with acquired heart disease. Congenital heart centers are familiar with all the different nuances of care that congenital heart patients require, and studies have demonstrated that adult patients followed at a congenital center have both longer life expectancy and better quality of life.
Why should I go to a congenital heart surgeon?
I would advocate that you should not necessarily go to a congenital heart surgeon. You should go to a center specializing in caring for adult congenital heart patients, and that among the other specialties in that center, it has congenital heart surgeons who are well versed in adult congenital heart disease. Such surgeons and surgical teams have the best understanding and familiarity with the unique problems adult congenital patients face. Caring for patients from childhood till adulthood provides a deep understanding and continuity of care required for serving an adult congenital heart disease patient.
When might a patient with adult congenital heart disease go to an adult or non-congenital center?
So you are an adult congenital patient and you have a medical problem requiring hospital care and you don't know where should you go to. So first, please reach out to your ACHD cardiologist. And if you don't have one, please let us know and we will help you to find one. Second, try to go to a facility that has the appropriate cardiac services to support you. Even if your current medical problem is not a cardiac one, you may require interventions and care that might be impacted by your heart's condition. For example, if you need a procedure done under general anesthesia, it would be vital to have an anesthesiologist experienced in caring for patients with congenital heart disease. Such support system is not available in every hospital. Is it okay for an adult to go to a pediatric center? If that center has an adult congenital heart program, then absolutely yes, because that means they have all the required adult-related subspecialty support that you may need.
What kinds of questions should I ask about a program to know if it's the right place for me?
In my mind, this is probably the most important question to ask. First of all, find out who is on the team. Does the team include the appropriate adult subspecialty support? Do they have, for example, adult gastrointestinal, liver, kidney, pulmonology support? Are the nurses trained in caring for adult patients? Does the program have social workers and psychologists trained in supporting Down syndrome patients and other adult congenital patients? Is that support system available 24/7? These are very important questions to ask while you consider where to receive your care. In addition, don't forget to ask how many adult patients do they care for every year. This will give you a good idea for their ability to best care for you.